Hello everybody, my name is Annika and I'm currently working in Lucerne, Switzerland. And our topic today is which patient should receive stress ulcer prophylaxis. Here are my disclosures. Probably the most important one is an academic conflict of interest. I'm a co-author of BMJ Rapid Recommendations. There are some guidelines around which have not been too specific, contain a long list of risk factors, and they have led to the situation where most of the patients in the ICU have received stress ulcer prophylaxis. However, last years have brought some new evidence and also already mentioned BMJ rapid recommendations, and we have a look at them. The first was the SUP-ICU trial, including patients at risk for GI bleeding, and saw that there was no difference between pantoprazole versus placebo in these patients at risk for GI bleeding. And they also performed a subgroup analysis, and there was no difference in all of the groups. However, their one subgroup analysis got some attention. We come back to this a bit later. And the conclusion of the study was that mortality at 90 days and the number of clinically important events, it was a composite outcome variable, were similar in those assigned to PPI or placebo. However, it needs to be mentioned that there were less episodes of clinically important GI bleeding in patients with PPI versus placebo. And then systematic review on risk factors of GI bleeding was performed as one step in our BMJ recommendations, published in a separate paper in 2019. And we see here the risk factors listed. Most of them actually, a confidence interval goes over 1. So the effect is not very clear. The only one that appeared to be prophylactic, so goes on the other direction, decreasing risk instead of increasing risk, was enteronutrition. This analysis was used for creating categories for patients having low, moderate, high, or highest risk of GI bleeding. And we saw that it doesn't make sense to use cumulatively the low risk factors, because the risk associated to these risk factors is similar as to the one of without any risk factors. So they are not cumulative, whereas cumulative risk should be applied for moderate risk factors, where 2 or more of them would move them to the higher category of 2 or more risk factors. And here evidence profiles performed for this systematic review and under BMJ guidelines. And we see here PPI versus placebo. Do we see that PPI results in less GI bleeding? And the effect is more pronounced in the higher risk groups. At the same time, it leads to more pneumonias, whereas there is a signal, but the credible interval includes also no difference. So it is in both directions. Effect is less clear as regarding bleeding. If we look at the H2RA versus placebo, then we see very similar results. In high-risk groups, the reduction of GI bleeding is important. At the same time, there is signal towards increasing pneumonia, and again, credible interval includes no difference. Whereas when we look at the head-to-head comparison, PPI versus H2RA, then we see that reduction in GI bleeding, in clinically important GI bleeding, is more here in PPI versus H2RA. And this led us to the following recommendations. It was, of course, a long process with a panel including also patient representatives, etc. And these are our recommendations. We suggest using acid suppression prophylaxis for patients with higher risk of GI bleeding, risk above 4 or higher. And you saw already the graph that should facilitate to identify these patients. And we also said that we suggest using PPI in these patients who should receive prophylaxis, whereas H2RA is also a reasonable choice. Both recommendations were weak. There have also been some post-hoc analysis of SUP-ICU trial. We already mentioned the most severely ill patients previously in this presentation. And here we see when they performed a post-hoc analysis in patients with SAPS-2 score 53 or higher, no, higher than 53, sorry. Then there was a significant difference. And they also looked at the risk factors and saw that more risk factors were associated with increased risk of serious adverse events in patients with PPI versus placebo. And there was another large trial, PEPTIC, recently published, where intervention was preferential use of PPI versus preferential use of H2RA. Preferential is important because it was a cluster randomized trial, and the use of PPI for 6 months and H2RA for the next 6 months, and the opposite for the other half of the ICUs was recommended, but clinician was always allowed to use the other option. And the conclusion of this trial was that the strategy using PPI versus H2RA resulted in hospital mortality rates where difference did not reach the significance. So here we see the post-hoc subgroup analysis of this study, and also here it was noticed that patients with higher severity scores may have higher mortality related to PPI. Regarding PEPTIC trial, there needs several points to be brought up because it was a cluster randomized trial, as already mentioned, and it resulted in quite a large contamination. So 20% of patients who were randomized to H2RA actually received PPI. And only 2/3 of the patients randomized to H2RA received at least one dosage of H2RA. Which was an interesting finding was that in sites with high compliance, they categorized sites with low and high compliance site being where less than 12% of H2RA group received PPI. And then interestingly, the direction of the effect was different. So mortality risk ratio was below 1 in this high compliance group, whereas it was above 1 in all the patients analyzed. And one more interesting factor was that the curves seemed to split very early already during the ICU stay. And this would kind of suggest a mechanism due to adverse event, which has not been noticed so far in all the studies addressing safety of PPI. And now here are all the studies that are, or all the patients actually included in studies. And this is the total number of all patients included in individual RCTs. Here receiving PPI and here receiving H2RA. And all the rest, all the other columns are from PEPTIC. And of course, the PEPTIC was a large trial, but and which was good and brought an important information. However, we also need to consider that contamination was also large. These are patients who received PPI who were actually analyzed as receiving H2RA. This slide is just to show the numbers or the magnitude of the effect. Despite this contamination and the problems with cluster randomized trial, we decided to perform a network meta-analysis, including peptic or precisely said sensitivity analysis for the previous NMA. And we did two sensitivity analyses. One was including all sites in peptic, and the other one only sites with high compliance. And high compliance site was already defined previously. And we saw that in regards to mortality, in complete peptic analysis, the absolute risk number is positive, so the risk of death appears to be higher in PPI versus H2RA, whereas in restricted peptic analysis, it is negative, so it suggests less deaths in PPI versus H2RA. However, in both cases, the credible interval includes no difference. For clinically important bleeding, in the highest risk group, the effect was clear in both, but more pronounced in restricted group. And in both cases, it is in one direction and also significant. So the results of the previous network meta-analysis underlying BMJ recommendations were actually supported by the sensitivity analysis, including peptic. And to summarize, risk of stress ulcer bleeding is relatively low in ICU patients. So we need to consider that we need to apply prophylaxis in many patients to avoid one event of GI bleeding. Excuse me. Prophylaxis with PPI and H2RA both reduce bleeding events. PPI may be slightly more effective. There is concern regarding increased mortality related to PPI, what I have addressed in previous slides. We don't know the mechanism, and it is raised in post-hoc analysis in two large trials, one of them being cluster randomized, and it has not been confirmed by a network meta-analysis. However, we might think that even more restrictive use of stress ulcer prophylaxis in the future could be needed. Take-home message from me would be restrict the use of PPI or H2RA to patients with high risk of bleeding, not applying to all ICU patients, and use the latest guideline to identify patients in whom to apply the prophylaxis. Thank you very much.